Greetings to my fellow surgeons, dear colleagues. Hi, this is Dr. Semanchal Goel, and today we'll be presenting a very interesting case. And there are important things to learn from this video. And I've right at the bat, I've started with side port creation. Notice the side ports are about 1 to 1.5 mm anterior to the limbus. These steps are very important as far as small pupils are concerned. I've noticed to this golden tip to keep your ports slightly anterior from the limbus in small pupil cases so that there are minimal chances of iris prolapse in small pupils. Once your iris prolapses from your main port during a cataract surgery, it is the best to not touch the iris till the end of the surgery. My boss used to practice this and he never used to touch once you have an iris prolapse. Just at the end of the surgery, he used to deposit the iris back into the anterior chamber. And this is a safe case to play with. I won't be having any problem with the iris prolapse because I have made my side ports and the main port anterior to the limbus. Going ahead with the usual steps, the patient has minimal degrees of MGD so that you can see this oily layer on the corneal surface. I've injected the air bubble in the anterior chamber. I've stained the capsule with the dye and I've filled the anterior chamber with adequate amount of visco so that there is no problem in Capsulorhexis. And just like that, I am aiming for a decently sized rhexis, that is around 5.5 to 6 mm. The cataract is around grade 4, so it would be in best interest to make a bigger rhexis. I don't want to get trapped in a small rhexis and ultimately land in difficult chops whatsoever. So yes, just like that, I have done some color correction in this video for you guys to appreciate the color of the nucleus, the grade, and the stained capsule. Once a color correction like this happens, details are fairly easily perceptible. Yes, this is a biplanar main port which I have made in a 30-degree fashion, going up into the eye and then making my main port parallel to the iris plane and entering the AC ultimately. So this is a biplanar main port. And yes, hydration is very important. If you don't spin that nucleus, it would be a real challenge. So I'm just checking the mobility of the nucleus like that. I'm just evacuating the saline trapped between the posterior capsule and the lens. And one final fill of the anterior chamber to coat that endothelium before I start my chops. And yes, I'm just going to reassure myself by giving it a good spin. There are some errors, some mistakes when you are operating cases like these. These are patients where you however polished surgeon you may be, you will have some degrees of sympathetic overactivity. Your adrenaline would be squishing out of your glands and it would be rushing through your veins at this time because the patient is being operated under topical anesthesia, the pupil is small, and the grade is hard. One of my retinal colleagues just told me that there are three things to notice: the corneal clarity, the nuclear grade, and the pupil. If two of these factors are not in your favor, it is better that the case is to be operated by a retinal colleague and not by a pure cataract surgeon. So in this case, as two of the factors are against me, that is the pupillary size and the nuclear grade, I'm just swimming against the flow of the river. But nevertheless, once you are in a habit of challenging yourself with such cases, yes, you have to step out of your comfort zone to be a brilliant surgeon anyhow. And so yes, as you can see, my tip is around 2 mm exposed from the sleeve. And as you all guys must be knowing, the more tip exposure there will be, the more release of ultrasonic energy and the heat energy in the anterior chamber would be. And the more it's a directly proportional relation on the post-operative day 1 corneal edema as well. The more tip exposure there will be, the more corneal edema there will be on day one. So I need a good tip exposure, and just like that I'm prying those pieces away from each other. And as you can see, the endonucleus is resisting my division, but nevertheless, yes, some after some superficial chops, as I was scared, I have grabbed hold of the courage, and I'm going ahead with strong impaling the nucleus, the belly of the nucleus. And yes, one heminuclei is being made, and this is one quadrant, I guess, of the nucleus. And I've asked my OT assistant to just switch continuous mode for me for around 10 or so seconds, and then I'll be switching the pulse mode again. At this time, because I realized the phaco is being applied in the anterior chamber itself, I'm fearful for the patient's endothelial count. And you have to be cautious in situations like these, and you have to fill the anterior chamber repeatedly with visco for those brilliant, smiling, happy corneas on day one. So um, I'll just zoom out for you guys to appreciate. It's best to operate on at this field of view. It's not advisable to operate all your cases in a very magnified view, as you lose the track of what's going on in the periphery as well. As you can see, just notice my tip exposure now. When I started the case, my tip exposure was around 2 to 2.5 mm. But now, because I am going to operate this case in anterior chamber, like slightly anterior from the normal iris plane that I operate them in because of the small pupil, I have I have made my tip exposure slightly smaller than the usual ones. So this is 1 to 1.5 mm tip exposure, which will ultimately result in a quiet eye on postoperative day one. These small changes in your operative methods are going to yield you greater results in your long-term future. So don't think that these changes don't pay dividends. They absolutely do in long run. The patient would be smiling. The case is gone. The grade was grade 4, and it was a small pupil. But yes, we are down to the last bit of nuclear fragment, and just look at that beautiful glow, the beautiful sunset orange glow that we talk about. These small tips and tricks of just making your tip exposure and just making those side ports and the main ports anterior to the limbus are golden rules that you need to remember for small pupil cases. I generally do phaco in the iris plane, but once you know that the small pupil is going to just challenge you, you have to take care. And once you know the phaco is going to be done in the anterior chamber, it's always best to fill that visco in anterior chamber and just go ahead with pulse mode, low energy. And yes, it's a beautiful IUL implantation in a small 50% pupil size. So this was a fun video to demonstrate you the importance of tip exposure. Tip exposure is very important. The location of side ports and main ports is also very important. We are down to the last 10% of the case, and I'll just give anterior chamber a final visco washout so that there is no IUP spike on day one. You have to replace all the visco with normal saline. And small pupil cases are also notorious for hiding those cortical remnants as well. So just make sure you nudge the iris away and see all the quadrants if they have cortex or not. And yes, that's all from my side. This is Dr. Semanchal signing off. This was a late video. I have not been posting a lot of videos from so many days. I hope you like my stuff. Kindly like, share, and subscribe. It would help my channel grow a lot. And thank you so much. Have a great day ahead. Please share these videos with your colleagues, with your fellow surgeons, and it gives me immense happiness when you guys share these videos and learn from them. Thank you and have a great day ahead.